We'd like to go ahead with the next presenter. We have Professor Fahad AlHameed. Fahad AlHameed is the chairman of the Saudi Association for Venous Thromboembolism, senior consultant intensivist and pulmonologist, professor of medicine and critical care College of Medicine, King Saud bin Abdulaziz University for Health Sciences, chairman intensive care department at King Abdulaziz Medical City, National Guard, Jeddah. He obtained the American Board of Pulmonary Medicine and Canadian Board of Respiratory Medicine in 2001, then the American Board of Critical Care Medicine and the Canadian Critical Care Medicine Fellowship in 2002. He is highly published with over 70 publications in highly reputable journals. We welcome Dr. Fahad, and he will be talking today about Saudi clinical practice guidelines for VTE prophylaxis. The floor is all yours.
Thank you, Mr. Chairman. And do you hear me?
Yes.
Hear my voice? Okay. I would like to take this opportunity also to thank the organizing committee for the excellent job on making this conference happening, and all my colleagues who are the previous speaker who gave the presentation. Make it easier for me. What I'm going to talk is basically on the Saudi clinical practice guidelines and on the VTE prevention and management and the journey that we went through. I like this quote by Hippocrates that in acute diseases, coldness of the extremity is a very bad sign. And this is applicable for both, whether it is blood clot in the arterial or venous. Before I go through the journey of the Saudi clinical practice guidelines, I would like to highlight on the impact of the problems worldwide and also in the Kingdom of Saudi Arabia. If we look at the impact of VTE United States, we'll find that VTE events kill up to 200,000 people each year, more than AIDS, breast cancer, and highway fatalities combined. In one study, the in-hospital case fatality rate of VTE was as high as 12%. Around 2 million cases between symptomatic and asymptomatic DVT developed in the United States, and 600,000 patients developed PE. And unfortunately, 200,000 ended with fatality. If you look to the data in Europe, which is based on the 6 large countries of Europe, there will be around it's been estimated that around 3.5 million of symptomatic and asymptomatic DVT, and 1 million patients develop PE, and 500,000 died annually because of VTE. 1% of all hospital admissions, unfortunately, they found they die from PE in the literature, and this 10%, around 10% of the hospital deaths are due to PE. Imagine that death related to VTE are equal to 2 747 crashes every day. How about the Kingdom? Until the beginning of the millennium, we didn't have much data to estimate the magnitude of the problem in Saudi Arabia. However, with the some of the epidemiological study that published recently, we found that VTE basically in Saudi Arabia is as common as in Europe and North America. And around 200,000 cases develop annually between symptomatic and asymptomatic, and 60,000 PE with fatality that range between 15 to 20,000. And I'm glad to see that our colleague, Dr. Saleh Al-Ghamdi, who's actively involved in the prevention of VTE at the MOH level, and happy to see his result and data that become more public and aware. VTE is often undetected until too late. At least 70% of fatal PE detected post-mortem was neither suspected nor diagnosed. Similarly, DVT in clinical practice. So basically what we diagnosed is only 30% and 70% of the cases goes undetected. And fatal PE diagnostic diagnosed at autopsy in medical patient has been consistent in the range of 70 to 80%. Approximately 75% of fatal PEs diagnosed at autopsy are in medical compared to surgical. People still think that VTE is common mainly in surgical and less common in medical. Unfortunately, it is more common in medical than in surgical. However, the awareness of the surgical patient is more than medical. And this has been consistent whether in the finding has been consistent whether in the United Kingdom or United States of America. Most of the VTE cases are undetected clinically because only 20 to 30% of the patient, they got symptoms, and 70 to 80% they go with no symptoms. So basically in clinical practice, we only see the tip of the iceberg. VTE is 100 times more common in hospitalized patients. However, VTE can still occur recently hospitalized and community residents. The risk of VTE is significant with either treatment, with the either undiagnosis and no treatment or over treatment. Not treating DVT may result in serious and long-term complications like post-thrombotic syndrome in up to 56%, PE in up to 32%, and death within 1 month in 6%. On the other hand, over-treating DVT may result in intracranial and GI plus other hemorrhages that could have been avoided. We have established the Saudi Arabian Venous Thromboembolism Advisory Group in December 2008. Some of our colleagues who are a speaker here, like Professor Yassin Arabi, Professor Majdi Idris, and others. I want to highlight on the first and the largest epidemiological study that we published after the establishment of this group is basically we looked at the thromboprophylaxis and mortality among patients who developed venous thromboembolism in 7 major hospitals, 2 MOH hospitals, 2 National Guard hospitals, 2 military hospitals, and 1 university hospital. Basically, at that time, in 2010, they were the largest hospital in the kingdom. And the finding here shows that a total of 1,241 confirmed VTE cases occurred during the 12-month period. And 80%, around 78.6% of the VTE occur in medical patients, and only 21% occur in surgical patients. Only 41% of VTE cases received the appropriate prophylaxis. The mortality rate was 14%, which represented 1.6% of the total hospital death. And appropriate thromboprophylaxis was associated with 4% absolute risk reduction in mortality. And this is very, very significant percentage of reduction of mortality had we applied the appropriate thromboprophylaxis. For conclusion from that study, thromboprophylaxis was underutilized in major Saudi hospitals, denoting a gap between guideline and practice. This gap was more marked in medical than surgical patients, and this is attributed to the awareness. The surgeons are aware of their patient that may develop DVT or VTE, hence they are active in prophylaxing their patient compared to the medical patient. Hospital-acquired VTE was associated with significant mortality, and efforts to improve thromboprophylaxis utilization are warranted. The background of Saudi clinical practice guidelines started in 2010 when we met with His Excellency, the Deputy Minister of MOH in the Sibahi headquarters in 2010 in Jeddah. and presented to him the CBT mission and goals with the initiative to promote and establish the evidence-based practice of VTE prevention in the kingdom, and provide guidance for the diagnosis management of VTE and reduce the variability in clinical practice. A further meeting in the following year was done, and he at that time give us good news that the MOH in Saudi Arabia established the Saudi Center for Evidence-Based Healthcare Center, and this center has multiple goals. One of them is to promote the evidence-based practice across the kingdom, develop clinical practice guidelines for diagnosis and management of several common diseases, and collaborate with the medical societies and associations. The Saudi Ministry of Health contracted McMaster University Working Group to provide methodological support, and contacted the Saudi Association for VTE, which is a subsidiary of the Saudi Thoracic Society, and also other societies to nominate a group of clinicians from various specialties to help and develop the guideline. This is the first meeting that was conducted in December 2nd and 3rd, 2013 in Riyadh, and you could see the group for the expert people here, Professor Abdul Karim Al-Mu'min, Prof. Hassan Al-Tursi, and other colleagues. And you could see here, Prof. Holger Sherman is the chairman of the Department of Medicine and the Epidemiology Department at McMaster University. The first day, the panel received training on the grade system, and on the second day, the McMaster group provided the panel with the pertinent literature summary and evidence to recommendation tables. 10 common diseases or conditions selected by the center included the VTE, one of them. In the first wave, the following topics that were selected as a CPG related to VTE. The CPG on DVT diagnosis, on the treatment of venous thromboembolism of outpatient versus inpatient management, and prophylaxis and treatment of VTE in patients with cancer. The same group met 2 years later in March 2015 in a second wave, and selected the following CPG, which is VTE in medical, prophylaxis of VTE in medical and critically ill patient, prophylaxis of VTE in long-distance traveler, and prophylaxis of VTE in surgically ill patient. After prevention, we thought what could it be more important is to make the right diagnosis, because we know that VTE, if we depend on physical examination, it's not always accurate, and the available diagnostic test may lack the sensitivity and specificity. Hence, the evidence-based diagnostic approach is crucial, and that to reduce the chance of not treating patient with DVT, and on the other hand, reduce the chance of treating patient without DVT. So the first Saudi CPG was on DVT diagnosis. This is the guidelines development process. I will not go through the details of it, but in the if we take the example of the DVT diagnosis, a few highlighted issues that related to the process, that invited panel selected 24 clinical questions using the formal prioritization process. For all the selected questions, the McMaster University group updated the related systematic review and conducted systematic search related to the subject. The recommendations were based on the available evidence, sensitivity, and specificity. The quality of evidence also according to the grade system, high, moderate, low, and very low. The panel took into consideration the patient's patient values and preference related to the complications of both DVT and DVT treatment. Utility values range from 0 to 1. 0 is attributed to the death, while 1 represents a perfect state of health. Also, the resource and diagnostic test availability in the kingdom, and the cost and cost effectiveness in Saudi Arabia. The recommendation were either strong, which is most patient would want the recommendation, or weak conditions, which is many patients may not accept the recommendation. The first publication was published in Saudi in the Annals of Thoracic Medicine in January 2015 on the diagnosis of the first DVT of the lower extremity. And I was honored to work with my distinguished colleagues, including the McMaster group. The same year, also, we published the Saudi Clinical Practice Guideline for treatment of VTE, outpatient versus inpatient management in Saudi Medical Journal. And the third publication on the CBG, the prophylaxis treatment of VTE in patients with cancer in the Annals Saudi Medicine. After the, as I mentioned, the second wave, we completed the task on the CBG for the prophylaxis VTE in medical and critically ill patient, long distance traveler, and surgically ill patient. And we managed to publish all of those three guidelines in the Saudi Medical Journal. What CBG and the future? The Saudi expert panel suggested local research on the values and preference of the Saudi people, the burden of treatment with the antithrombotic agents, the cost effectiveness of the different strategies employed for DVT diagnosis, and the cost effectiveness of the different strategies on VTE prophylaxis and management. What was next? The challenging task. It appears that guidelines was the least challenging task. However, what was next was the steps that needed to be done, which include the dissemination of the guideline through presentation, education, having it accessible at the Savity website, medical journal, and applying the smartphones. Implementation of the guidelines, which has been more or less done across the kingdom, additional guidelines related to VTE prophylaxis and management, and constant updates of the CBG. Unfortunately, some of this task was not been able to be completed because of the center has been closed and the contract with the McMaster terminated. Recently, a group of our colleagues under the umbrella of the Saudi Health Council has been alluded in the previous presentation by our colleague Dr. AlHameed, managed to produce this document again and started the process from the beginning. However, I'm not aware of if it was built on the previous recommendation or standalone document. To my knowledge, it was not published in the medical journal yet. On the other hand, just to put the people the perspective of the international guidelines, we all know that CHIST are a leader across the world on producing the VTE guidelines. Recently, they published the updated guidelines in August 2021. It's called the second update of the CHIST guidelines and expert panel report executive summary. And I just would like to highlight on some of the important, because developing guidelines is very, very difficult and challenging, and maintaining it is much more even difficult. they clearly stated in their introduction that CHEST has been developing and publishing guidelines for the treatment of venous thromboembolism for almost 40 years, and the last full edition of the guideline of the anti-thrombotic therapy and prevention of thrombosis, 9th edition, 89, was published in 2012, and they built on it. So in summary, the CBG recommendations are not dictate. CBG must be peer reviewed. CBG must be owned by scientific body or bodies and must be published in respective medical journal in order to be accepted as a scientific publication, must be reviewed and updated periodically. No CBG that can take the account all of the unique features of the individual clinical cases, and educational interventions may be needed to overcome potential expected initial resistance. Some recommendation may become quality indicator. And this takes us back again in the presence of the continuity of the ANA, the recent publication of the guideline in CHEST, to the again fundamental questions, which is, do we still need to produce our Saudi guidelines? And I believe the jury is still out. Thank you.